So everything I'm about to tell you, you guys should already know because you know how to do all the simple and advanced coiling. Does this go? No. All right. I guess it's just a pointer. All right, no disclosures. So I just wanted to go through some of the equipment, and then we'll go through some simple coiling, vessel takedown, dual microcatheter, balloon-assisted, and then stent-assisted coiling, just to kind of get you up to speed. Typically, we use femoral access. Axillary and brachial has been described. I've not used the axillary or brachial approach myself. We're doing more and more transradial now, much more than I guess what I did in my training, just because the equipment is much, much better than what it was even a few years ago. We have much softer catheters, so we're doing a lot radial. Carotid cut down was a skill, particularly for flow diversion, that you kind of had to have in your arsenal when pipeline first came out. We're doing that less and less now because, again, the catheters are much more softer and can get around these loops in the neck and these difficult anatomies. And collateral circulation, you saw Dr. Dumont presented a P1 stent, so coming from the carotid side and then going across the PCAs. There's lots of different arches. We're really lucky here. We have Shane Tubbs, who's the top anatomist in the world, as you guys know, the editor of Netters and Gray's Anatomy. And so when I see a really weird arch, I just go upstairs and I ask Shane what I'm looking at, and then he'll tell me and then point me in the right direction of a book that he wrote. So it's kind of, you do see these different arches. The main ones that we worry about are these type 3 arches, particularly if you're going to the right side. It can be very challenging to get into these right internal carotid arteries and so forth. And we've definitely been using transradial approaches for a lot of those cases now. Bovine arch, most of you are familiar with that, the left common carotid coming off the innominate artery. You can get difficult arches like this. This was a patient of mine who had a pica artery aneurysm, who had a duplicated aortic arch. I have never seen one of those before. I'll probably never see one again, but basically his esophagus and trachea went between this donut of aorta. So I didn't know he had that when I first did his diagnostic angiogram, and you can imagine how confusing it was to try and figure out what the heck was going on with that arch. But we were able to get a diagnostic angiogram with this initial study, and then we ended up treating his pica aneurysm transradial. And then you can have a so-called ridiculous arch. This is a patient with Louise Dietz syndrome and intracranial aneurysm. He'd had a aortic reconstruction as an infant, and this was kind of the impossible arch. We didn't know he had all of that going on until we started angioing him.
Which ended up?
Yeah, it's a bit like that. It's none of it's normal. It's all been put together. So access catheters, we've got the sort of tower of power principle with coaxial systems. We typically use an arrow sheath, which has a braided metal it's a very firm sheath. Intermediate catheters, and then the microcatheters, all of which you've used in the lab. They can be pre-shaped, or you can steam them, so you can shape them into whatever shape you want. I found the pre-shaped ones to be to kind of hold their shape a little bit better than the steam, but certainly when Dr. Dumont was training me, we had a steamer in the room at all times, because we used to have to steam the catheters a lot more. We don't do that anywhere near as much. And the micro wires are all different torque abilities and different shape abilities. Collateral access, particularly for PCOMs, can be useful, and the pica aneurysms often will go from the contralateral vert because it's sometimes hard to get out the ipsilateral pica, and if you come from the other side, often the angle is easier to go out the pica. It's kind of a straight shot if you're coming from above. As I mentioned before, you can get these difficult arches, and so often a transradial approach is better. So the radial cocktail, we give verapamil, nitroglycerine, and heparin. There's a whole range of different recipes that you can use. But that's the one that we typically use. So you put the access in, and then you give the verapamil, the nitroglycerin, and the heparin. Typically, you should do a Allen's test pre-op and make sure that when you include the radial artery, they've got good collateral flow through the ulnar branch down to the arcade of the hand. We can use a 7 French sheath. We've used a Sophia Plus typically, and then the usual microsystems. So this is a pica artery aneurysm that was treated, and this is the transradial approach for that patient that I mentioned who had the double aortic arch. In this case, was actually treated with an Elvis junior stent without coiling. So we've done this for I think 7 cases now. Dr. Lowe's just writing up our series where we've used the Elvis junior stent in the pica artery. I think for 3 or 4 of those cases we didn't need any coils. We did one a week ago. Same thing, as soon as we put in the stent, the aneurysm basically just disappeared. So there's a kind of a flow diverting effect from that stent. And then we had a 6-month follow-up which shows obliteration. So this is another pica artery aneurysm. Same thing, treated with a kind of a contralateral vertebral artery access for the reasons that I mentioned. The red arrow showing where we would put the stent, and then the green arrow there showing where the coiling catheter is. And this patient had 2 aneurysms, a basilar artery aneurysm as well as a pica artery aneurysm. So you can often use just the angle. Sometimes the takeoff of the pica artery is at the very edge of the aneurysm, and it's risky trying to go around that corner. Some of you on the simulators are trying to get into the PCA, kind of poking the neck of the basilar aneurysm on the way past. We often get that, and so a contralateral approach can be helpful there. This is a 63-year-old with a history of methamphetamine abuse, 10-day history of headache, woke with the worst headache of life, and she had this Fisher grade 3 subarachnoid hemorrhage. So we put in an EVD, and the CTA demonstrated 2 left middle cerebrals, 1 right middle cerebral, a basilar bifurcation, and a left pica. So we're dealing with this M1 segment aneurysm, as well as a smaller 3 millimeter bifurcation aneurysm. And then on the right side, there was a anterior temporal artery aneurysm. And then we also had a basilar bifurcation aneurysm and a pica aneurysm. So there's blood everywhere. What would you do for that? Any volunteers? So you have 5 aneurysms. We're just going to let her hang out in the ICU.
Left one is what we suspected is the one that's ruptured.
Yep. So we did a left craniotomy, clot evacuation, and it was a ruptured left anterior temporal, and we took the bifurcation aneurysm as well. Did ICG. So you're right. You did the right thing. And so we let her recover from the operation, and then post-bleed day 28, we brought her back and took care of this basilar and the pica. And so we did the basilar just with simple coiling, and then kind of fast forward. Sorry, we used a stent coiling. So a stent into the left PCA with coiling, and then that's the final result for the basilar. And then for the pica, as I mentioned, the left pica is coming right off at the neck of that aneurysm, so that can be a kind of a tricky one to get into. And so we did that with, you can see there on the native, we ended up putting a stent out the pica, and then we're able to coil up through that stent and occlude the aneurysm that way, and that's the final 3D there. So just like Dr. Dumont presented that case with sort of multiple aneurysms, different modalities of dealing with it, then this was the same sort of patient. You have to guess which aneurysm is the most likely one that ruptured, go after that first. The nice thing about surgery is you can actually see if there's a hole in the aneurysm and you know that it actually bled. If you've got clot around that area, same thing. But sometimes you just don't know, and in that case you have to take care of all of them. So in terms of the coils, there's different types for different purposes. There's the framing, complex or 3D shape, and then the filling type, and then the finishing type. There's different lengths, there's different shapes, different kind of additions that Dr. Dumont had also mentioned. There's these new 3D coils that a lot of the companies have now, and they kind of form a box. They're really a little bit more sort of rigid than some of the earlier complex shaped coils, but they can really kind of form a cube shape, which can be really helpful for wide-necked aneurysms. So a lot of the aneurysms that we used to balloon assist, we're now treating with 3D coils as the framer, and we don't need to use a balloon. And so once we've done that frame, then you have the filling coils to just kind of pack in, and then you have these small little finishing coils, which are very, very small, very, very soft. The helical coils tend to kind of burrow their way into gaps, and so we usually use those for finishing. There's all sorts of additions. You can get fibered coils. So if you're taking down a vessel, you might want to use a fibered coil. They're very thrombogenic. Some of you might have been using one of the models where the coated coils, the PGLA coated coils were mentioned. So there is a recent study out which suggests that these coated coils have lower recanalization rates as well as lower retreatment rates. So the early generation of the coated coils was, they're a little bit difficult to use. You only had a certain amount of time that you had to deploy the coil before you could not resheath it because the coating had expanded. That's not the case anymore. And so that's kind of a promising new technology. The detachment systems, electrolytic, pressure, or mechanical. So there's different ways of these things detaching. The mechanical one's probably the most reliable. It's pretty unusual for them not to work. Occasionally the electrolytic ones don't work, but as every year goes by, the companies get better and better. So it's pretty unusual now. I can't remember the last time we had a coil that we couldn't detach. So the ethos is kind of the keep it simple principle. You don't have to find the most complicated way to solve the problem. The fellows always want to find the most complicated way to solve the simple problem because they want to see lots of weird things. But really, you want to do the simplest thing. If you can just do coiling without a stent, you should do that. If you don't have to use a balloon, don't use a balloon. So it's keep it simple, but you also want to have a plan A, B, and C. And be meticulous about everything, particularly antiplatelet therapy. You want to make sure your Plavix response is therapeutic before you get into the IR suite. I typically load everyone on aspirin and Plavix, so if I have to drop a stent, if there's a coil that has a tail dragger or I have to put in a stent, they're already on Plavix, so it's not a big deal. You're not worrying about giving ReaPro infusions and stuff like that. You want to have good working projections. The 3Ds helped us a lot. Rather than having to kind of look around for different angles, the 3Ds are pretty good at getting you to where the right angles are pretty much straight away. Sometimes the angle for the stent is different for the angle for the coiling. It's important to know that. Typically for anterior communicating artery aneurysms, you often have to have a single view to get into the A1, and then you might have to change your view to get the microcatheter into the dome of the aneurysm, just because of the nature of the anatomy. So it's important to kind of realize that. You want to have a bailout plan, as I mentioned, plan B, C, D, E. And complications, you have to kind of look for the complications first. They happen to everyone, and you want to keep your eyes out for those. So simple coiling, you want something that either has a really good neck to dome ratio or looks like a windsock, like this guy's hairdo there. Patients, subarachnoid hemorrhage, those are not going to tolerate dual antiplatelet therapy, or as I mentioned, the kind of light bulb aneurysm or the so-called windsock. Sometimes you can get this sort of a hidden neck or shelf at the neck of the aneurysm, which can be useful. But these complex coil shapes that I mentioned, these 3D coils, have kind of changed the game on that a little bit. The sort of so-called wide neck can be pretty wide before you need to use an adjunct like a stent or a balloon. So you all kind of know what the ideal is: a nice narrow neck with a large dome, and then there's the fusiform as kind of the other extreme, like the case that we just presented, which would be more suitable for something like a flow diverter if possible. So narrow neck is ideal. If it looks like a light bulb, it's kind of sort of your coiler's dream, and so those are the ones we're looking for. If it looks like that, you're in pretty good shape. We're pretty able to coil just about all of those. I'm from New Zealand, so I have to have a rugby picture in there somewhere. Sometimes you can have a very broad neck, like this chap here, and with a broad neck, you're going to have to use adjuncts. So I'll just go back. See if we can get this to play. Okay, so this is just a simple coiling of a PCOM aneurysm, and you can see there the microcatheter going up. Typically like to keep a loop or a J when we're going up with a micro wire. It's really hard to go down perforators when you have a loop in the wire. And then often with these PCOM aneurysms, when you just kind of fall back, it'll just flop into the aneurysm just like it did then. So sometimes just going past the aneurysm, letting all the energy in the catheter wire system get released into the terminal carotid, and then when you're pulling it down, the whole system will just kind of fall into where you need to go. And then obviously just advancing the microcatheter. And as we're removing the wire, we're gently pushing the microcatheter forward, because as you pull the wire out, it tends to pull everything out with it. So we're putting a little bit of gentle forward pressure as we do that. And then we can begin our coiling. For a nice narrow-necked aneurysm like this, you can it's pretty straightforward. You can be reasonably aggressive. You know the coils are not going to come out because it's such a narrow neck. So once we've got our first framer in there, we'll detach that. And then see how far we go. So the framer looks good, and we can detach that, and then we just continue to pack that on with more and more coils. Most of you have all kind of seen that. So in the interest of time, I'll move along, but that's the kind of basic principle with simple coiling. So vessel takedown, this has been around since the time of John Hunter. So Hunterian ligation is a very valid way of treating many aneurysms, particularly these large carotid aneurysms. It's not ideal to take out the carotid if you can do a flow diverter or something else, but for some patients it's a good option. You've got to do a balloon test occlusion first to make sure they tolerate it. Aaron presented a case where they failed within seconds. That's a bad sign. They're clearly not going to tolerate a balloon. Going to tolerate a carotid occlusion. So typically what we do is we inflate the balloon, patient's heparinized, and if it's done awake, we will typically drop the blood pressure by 20%, and then you'll want to keep the balloon inflated for 10-15 minutes and make sure the patient tolerates having the carotid occluded. And you can look at the other vessels while you're doing that, and you're continually examining the patient. You can do it with neurophys as well if the patient is already intubated or something from a subarachnoid, but it's important to get adequate testing before you take down the vessel. And then in terms of how you take it down, typically we take it down with coils. We've used this MVP plug device as well, so it's kind of a one and done. It's kind of a cage with a little PTFE coating on the outside, which basically occludes the vessel immediately, and that's another elegant way of doing it. So this is a young patient in her 20s, came in with some headache and had this CT angiogram. and this CTA here showing this very large thrombosed or partially thrombosed vertebro-basilar aneurysm. This is the 3D CTA. And then on the angiogram, it's kind of an interesting angio because all you're seeing is the filling component here. There's a whole big thrombosed portion which is right up against the brainstem. And so what we did here, this is a balloon in the vertebral artery. And so you can see in the second panel, the balloon's still inflated, and we're now injecting into the right, as well as injecting into the left internal. And you can see the basilar system is filling retrograde through the PCOM. So we did our balloon test occlusion, and then we sacked the vessel with coils as well as an MVP device. So we put that little plug in, and that was kind of the final result to occlude that vessel. And then what we did after that, you can see there's a little residual there, but there's good filling of the basilar, both from the internal filling retrograde as well as from the lower half of the basilar filling through that small right vertebral artery. And so what we noticed over time is that this aneurysm shrunk down over several months. There was a little residual, which I went on and coiled. And that patient has gone on to continue to shrink down her aneurysm and is totally intact from a pretty kind of nasty lesion. Yeah, it's got a little bigger. Yeah. So it's kind of, the basilar trunk was filling both from retrograde and antegrade. So dual microcatheter technique, this is described by a former colleague at UVA who was a big proponent of it. So it's the idea of using two coils to kind of mesh in against each other. When you don't want to use a stent or a balloon, you don't need to have dual antiplatelet therapy. And so this was a case of a pica aneurysm. Hopefully it'll move forward here. So there's different options that you could do for this. You could stent coil. This is a patient that also had a basilar at the same time. So we coiled the basilar with simple coiling technique. And then similar principles. This is a pretty small aneurysm. I think now, with our experience from putting the Elvis stent out of the pica, I'd probably do that now. But this is a case where I didn't use a stent, and then we can put two microcatheters into the aneurysm dome at the same time. The tricky part when using the dual microcatheter technique is you have to remember which coil is going out which microcatheter. And especially as you're advancing more coil, you need to make sure that you don't prematurely detach the wrong coil. It sounds simple, but it's easy to get mixed up because the two are right beside each other, and the coils are usually similar length. So as you're going up, it's hard to remember which one is which. So this was a dual microcatheter technique, and hopefully we'll see the coils coming out here in just a second. And the whole idea here is that the coils kind of intermingle into each other, and so it gives it more body. If you just put one coil in, it was tending to fall out. So I tried putting these coils in kind of simultaneously so that they kind of get stuck all in each other, and it just gives the whole system a little bit more of a robust body. And you can see the coils going up here. And it's a little bit finicky. You have to be kind of patient with it because you'll put in a little bit of one coil and then the other one will start coming out and so forth. So you kind of have to work at it a little bit. But we're able to get this to work. And by the time we're done, you can get a nice result without the need for a stent or a balloon or something. So it's just another option.
One coil for each catheter, just one coil.
in that case, yeah, it was one coil on each catheter. So the trick is getting the right coil, because yeah, if you need to get another one in there, it can be tricky because the last coil is going to be hard to kind of intermingle. But in that one, we just used one coil in each with a complex 3D shape. So it's important to know, yeah, so like I said, you got to know which coil is going down which microcatheter, so you don't detach the wrong one. Yeah, whether you use the same coil or whether you use one soft coil and one ultra soft, that's kind of another thing to consider. So it's just kind of playing with it. Balloon-assisted coiling, this can be really helpful in subarachnoid hemorrhage. Vivek and I were just talking about these 3D coils during the break, and we're finding we're using the balloon less and less. I know you were trained by Dr. McDougall, who was a big fan of the balloon, and so he was still a big proponent of that. And so it's another good adjunct, particularly in subarachnoid hemorrhage when you don't want to use dual antiplatelet therapy. You've got to be familiar with the balloon. You've got to know the compliance of the balloon so you don't rupture the vessel. You should know how much to inflate the balloon. And it's also really important to test inflate the balloon, typically in the petrous carotid or somewhere. You know, if the balloon's been prepped with saline, that's a bad thing. You have to make sure it's prepped with contrast. So the kind of the golden rule is prep the balloon yourself, or you're definitely watching whoever's prepping the balloon, make sure the contrast is going in the balloon. The runaway balloon phenomenon. So when you've advance the balloon, you need to pull the slack out of the balloon, because what tends to happen is once it inflates, if there's slack in the system, it'll go flying because it's like a sail. So you need to advance it to where you need to get to and then pull the slack out so that when it inflates, it doesn't go flying up into the distal vessel. So this is, there's the test inflation in the petrous there. So I'm taking my own advice, making sure that I've actually got contrast. And this is a superior hypophyseal aneurysm in a young female patient. She was looking at getting pregnant, and so we didn't want to have any dual antiplatelet therapy on board. And so a balloon was used, again going up with a nice kind of a gentle J shape or loop. Will keep you from going down perforating vessels. Then we advance the balloon. And again, we just pull the slack out there. So we're pulling the slack out of the balloon so it doesn't go flying. And then we can advance the microcatheter into the dome of the aneurysm and inflate the balloon. And then we can begin our coiling procedure. And there's different techniques. One way to do it is to deploy each coil, and then here's the balloon going up. So there's different ways you can do it. You can either deploy all the coils and drop the balloon down. Some people prefer to drop the balloon after one or two coils. Really kind of depends. If you've got a really wide neck, I tend to keep the balloon up because I'm worried that I'm not going to have enough mass of coil to keep the coils in there. The risk, of course, is if you've got a wide neck and a kind of a loose packing after your first coil, if you deflate that balloon, then the whole thing is going to go flying. So we tend to keep it inflated until you've kind of completed the coiling. So more coils going in. It's important to keep an eye on the balloon to make sure that it's not deflating by itself. And then you can continue to use softer and softer coils to pack the aneurysm. See if I can move this along. Okay, doesn't look like it. Hopefully it's just one more coil. There we go, last guy going in, I think. It's important to deflate the balloon slowly. If you start seeing the coil ball move, that would be a good opportunity to inflate the balloon. Another technique that's been used is using the scepter balloon. So there's a dual lumen balloon, so you can inflate the balloon, and as you deflate the balloon, if you see the coil ball starting to move, then reinflate the balloon and then just drop a stent. Dr. Patel does that not infrequently. So that's the final. So it's a nice result without having to use a stent. Stent-assisted coiling. You can jail or you can go through the stent tines. We'll go through what that means. It's important to understand the different types of stents, whether they're open or closed-celled, whether it's a braided type of stent. So a braided stent, like the Elvis stent that you guys use, is braided, so the braids separate out, whereas the Atlas or the Neuroform stent, they're an open-celled stent, so they tend to open up, which can make it easier to go around corners and also to poke through with a microcatheter. As was mentioned in one of the previous talks, there's different techniques, Y-stent, T-stent. You can do the jailing technique, which is my preferred technique, where I jail the microcatheter in the dome of the aneurysm and then drop the stent behind or on top of that microcatheter. That gives you a lot of stability. So when you start coiling, the microcatheter tends not to deflect or move around too much. The other technique is to just go through the stent tines, sometimes in smaller vessels like ACOM aneurysms. Sometimes it's hard to go through the stent tines, or you're really having to push the micro wire catheter system, so I tend to jail. And again, it's just the different types of cell design. The Enterprise is a closed cell design, the Neuroform's an open cell design. There's a whole range of different stents out there with different kind of designs. This is I think that's the Cerenovus device that you guys just used. I'm just blanking on the name. Pulse Rider. So hopefully you guys had a chance to play with that one. And Elvis stents. So as I mentioned, I tend to jail Elvis. So that's my technique. Here's a basilar tip aneurysm. This one was done with a P1 stent. So this is just the intraoperative angio showing that we've got a catheter in the left vertebral artery and one in the right internal carotid artery. And so what we're doing here is we're doing a simultaneous roadmap. So you're doing a roadmap of the internal and the vert at the same time, so that you can really map out the PCOM artery, which is obviously important to find your kind of roadmap of where this is going to go. So it does require accessing both femoral arteries, or in this case, you could go radial in one, and then just go up to the carotid in the other. And then the technique there, you can see on the native there, we just put an Elvis stent from P1 to P1. And it's important that you try not to deploy the stent into the PCOM, because it can get pretty tight. It can be difficult to remove your catheter and wire systems. But these stents are pretty flexible compared to the ones we used to use for this application. And then you can coil through. So this is a jailed microcatheter, but again, it's in this setting with the P1, it's pretty easy to go straight through, because you're going right through the middle of the side of the stent, rather than being up inside the lumen of the stent and trying to poke out. So that's a technique there. That's the post-op with a 6-month follow-up we did yesterday. I've only got the 3D. They haven't loaded the final regular runs. This is a giant basilar tip aneurysm. This is a bad actor. These are pretty tough cases at the best of times. This is just the last case to kind of finish up. There's a whole range of techniques that you can use to kind of get out of these giant aneurysms. This is the so-called around the world or over the dome technique. What you didn't see is the 2 hours it took to get to this point. The access was very challenging. This case had been previously attempted by a colleague somewhere else. and the vertebral arteries were just awful. So to even get a picture took us about an hour. So this is a very challenging case. Here we are getting the microcatheter out the P1, and the goal here was to do a Y-stent procedure. The most difficult PCA to get out was this one. So once we got the microcatheter, micro-wire system out there, we're now able to deploy, this was an Elvis Junior. So we're deploying one Elvis here across the neck of the aneurysm from the right P1 to the basilar. I'm not sure if there's any other great options. There's no P1, no PCOM to do a P1 stent on this patient. I think the pulse rider is an option, but its wings are not even wide enough on a case like this to really protect the two PCAs. And so the next part of that was to put another stent out the left P1 into the basilar. So here we are doing that. And the goal there was to protect both PCAs so we could Y-stent it. So in this case, you can't really totally jail, or it's difficult to jail, unless you have a second system because you've got two stents that you're using. So that was the stents, and then we put a whole bunch of coils in there. I think the challenge with some of these very, very large aneurysms is you seem like you're putting in coils forever, and it's really hard to tell exactly how many coils or how much packing density you've got in, because after a certain period of time, there's just lots and lots of metal. And as long as the coils are going in freely, you can just keep going for a long, long time. So this is one of those days where the boxes of coils that we used just kept stacking up. So I think that was the final, sort of a golf ball with a good result. At follow-up, I don't have the follow-up in this slide, but there was some compaction at the base, which is pretty common with these giant basilar tips, and I'm not sure there's it's kind of a perfect solution for these. Maybe a flow diverter, but we don't really have T-shaped or Y-shaped flow diverters, so I don't think there's even a web device that's going to be big enough to deal with that situation, but maybe Vivek in his next talk would have some solutions to that with a flow diverting talk, but I'm not sure if we've got a great solution for some of these. So just in conclusion, simple coiling is the way to go if you can do it, but we do have other adjuncts with stent-assisted coiling, balloon-assisted coiling, dual microcatheter techniques. It's important to know all of those techniques because each aneurysm is different, and you've got to have kind of lots of tools in the toolbox so that you can do what you need to do, and sometimes patients can't be getting stents and that sort of stuff. So it's important to know all those different techniques. That's it.